Hey everyone, today's guest is Dr. Roger Schwelt. Dr. Schwelt is currently an associate clinical professor at the UC Riverside School of Medicine and an assistant clinical professor at the School of Medicine and Allied Health at Loma Linda University. Dr. Schwelt is quadruple board certified in internal medicine, pulmonary diseases, critical care medicine, and sleep medicine through the American Board of Internal Medicine. He's also the creative voice behind the popular YouTube channel Medcram. And for those who don't already know, I'll link to his channel in the video's description. So with that, welcome Roger, and let's get into the presentation.
Hey, thank you so much, Michael. It's a pleasure to be here. And something really that's passionate for me is this understanding of light and what it can do to disease. I'm actually more and more surprised about some of the things that we're seeing. And we'll get into that today. We'll get into the science of it and then actually some case presentations as well. So this actually is a lobby of a hospital in India where they're actually constructing hospitals now to allow more natural light in. And it's because of the data that's coming out. And I think we may be a little bit behind the world in terms of this, and I'll explain why that's the case. Longevity, which is what we all want, is hampered, and specifically the enemy of longevity is chronic disease. And we've seen this actually for quite some time now. Um, Things like heart disease, diabetes, obesity, dementia, inflammation, long COVID, cancer, all of these diseases really are things that if you were to get it, it would sink your chances of having a long and fruitful life. Interestingly, all of these things have in common one thing, and that is mitochondrial dysfunction. And this goes along with the idea that mitochondrial dysfunction is the central core of the aging process. So as we get older, our mitochondria make less ATP. ATP is the fuel that allows your cells to be animated. And as we get older, these batteries in our cells make less energy. And that is presumably a lot of what we see as we get older. So heart disease, diabetes, obesity, all of these things are a result of our not being able to metabolism very well. So if you think of the mitochondria as an engine in your car, for instance, which gives you locomotion, it makes your car go, but it also generates heat in the process of doing that. And the process of doing that, that heat can actually make the engine less efficient and actually kind of shut it down. So the mitochondria uses fuel. It uses, proteins, fats, glucose, things of that nature, and it makes ATP. So this is really important about what it is that's going on because it also makes carbon dioxide and energy. So this is really important. As you're young and these things are working really well, as you get older, they don't work as well. You don't make as much ATP, and that's the big problem. So just like the engine has heat in your car that you have to deal with a cooling system, the mitochondria also make something called oxidative stress. That is the heat, that is the situation, that is the oxidative stress that can shut down the mitochondria and make it less efficient. And that's what happens as we get older. So we're finding out that the science shows that melatonin, which is a very powerful antioxidant, probably one of the most powerful antioxidants known to man, can actually mop up this oxidative stress and keep your mitochondria functioning well. It's kind of like the cooling system of your engine. This is the melatonin for your mitochondria. Now you may think, oh, melatonin, that's the thing that is secreted from the pineal gland. That's what we do when we sleep. That gives us great sleep. You're right, that is true. But in fact, a lot more melatonin is produced in the mitochondria. This is a paper that was published, and I'll show you this in a second, in 2019 that shows that there's way more melatonin that's produced in the mitochondria that is produced in the pineal gland. And here's the point. The point is that we're now starting to understand that there is a substance which is absolutely free, does not require a supply chain, which can actually increase production of melatonin in your mitochondria, in your cells. And what is that? As it turns out, as you may have figured out by now, it is actually sunlight. So sunlight actually improves that. Now, let me explain. Sunlight is made up of many different types of wavelengths. The majority of the photons from the sun are actually made up of something called near infrared radiation. So let's take a look at that paper. Russell Ryder, Scott Zimmerman published this in 2019 in Melatonin Research, and this is an excerpt from that paper. They say now that it's now been shown that the mitochondria produce melatonin in cells in quantities which are orders of magnitude higher and that are produced in the pineal gland. This subcellular melatonin does not necessarily fluctuate with our circadian clock or release into the circulation system, but instead has been proposed to be consumed locally in response to free radical density within each cell, in particular in response to near infrared light exposure. So look at that. The pineal gland, less than 5%, mitochondria all throughout the body, greater than 95%. This is really the lion's share of where it's coming from. So if you want to understand near infrared light, you've got to understand a couple of things. It's outside of our visible spectrum. It's beyond red. You can't see it with the naked eye, yet you can feel it with the human body. It's that warmth that you feel when you go outside in the sun. And more specifically, it can penetrate through your clothes, it can penetrate through your skin, go deep within the body, and actually interact with the mitochondria in your body. This is something that is well known. It is a well-known characteristic of energy that has a low frequency. You may have noticed this when you are listening to an electrical storm and it's very far away. The first sounds that you hear are low frequency sounds. You know, when you pull up to a stop sign and that car pulls up next to you and they're playing that really loud music, all you hear is the low frequency boom, boom, boom. That's because that's the only energy that can really penetrate through their car, your car, and vibrate the steering wheel. The point here is that low frequency energy, like infrared light, can penetrate very deeply. This is a picture of Dr. Robert Fosbury's hand. He's a astrophysicist that works at the European Space Agency, worked on the Hubble telescope, worked with NASA, and he's putting his hand in front of a near infrared light source and picking it up with a near infrared camera. And as you can see, the light is going literally right through his hand. You cannot see bones because it's going through the bones. The only thing that's actually blocking it are the blood vessels, and that's because water absorbs infrared light. That's why that infrared light, when it goes into your body, it's going to scatter all throughout your body and then get picked up by these weak absorbers that are specifically in the mitochondria. And there's an amazing work that happens there in the mitochondria when that near infrared light goes through. As you can see here, the longer the wavelength, the lower the frequency. To the right now on this side, the deeper that this light is going to penetrate into the human body. Here's another paper. This is from Scott Zimmerman and Russell Ryder in 2019 again, looking at how deep does this infrared light actually penetrate down. And it scatters, right? So it's not just like how deep does it penetrate, but it's also how long does it take for it to scatter and then finally get absorbed by a weak absorber inside the body. 8 centimeters. That's a huge distance that this is able to penetrate down with just regular 900 nanometer infrared light. So this is a study that was done looking at the clothes that we wear and whether infrared light can penetrate through that. You can see here many different types of materials. And here's the point. On the x-axis, we have the number of layers of fabric. Notice that we're getting up to like 13 here before we start to see any kind of diminution of the amount of energy from near infrared. Like nobody wears 13 layers of clothing. Usually it's 1 or 2, and you can see here very clearly that you're going to be getting at least 50% of the infrared light that's coming to you from the sun to your body, even if you're wearing 1 or 2 layers of any type of clothing. The other aspect of infrared light that's really interesting is that trees are highly reflective of infrared light. Not just trees, grass, leaves, anything that's green. And so if you go outside hoping to get infrared light, you're going to get it, but you're going to get 2, 3, 4 times more if you're in a green environment because it's going to be coming to you from all angles and you're going to be just lit up with infrared light. You don't see it, you just see green leaves. This is going beyond that. And you're seeing this infrared light. Now, infrared light is something that carries heat along with it. You experience this heat. And one of the ways that you know that this is true is when you go up to the trees and feel the leaves, even on a hot day, hot sunny day, those leaves are never hot. They reflect that light very well. In fact, the coolest place in a garden is underneath that tree because those leaves are reflecting away that very hot infrared light. So to review, near infrared light coming into our body, whether it's outside, whether we're in a garden, whether it's green trees, it's going to penetrate deeply through that skin, bounce around. It's going to interact with our mitochondria to reduce oxidative stress, increase ATP production, increase carbon dioxide production. And as a result, it's going to use up fuel. And so your glucose levels are going to drop. So you're probably saying at this point, okay, what's the evidence for this? Well, Glenn Jeffrey, University College London, published this year, showing that in subjects that were given randomized red light, this was 670 nanometer light, those that were given a 75-gram bolus of glucose had a had a smaller increase in blood glucose than those that didn't. In other words, the blood glucose was reduced because the mitochondria were so energized that they were using up the fuel and they were producing more energy in this situation and more carbon dioxide. They actually confirmed that by measuring the exhaled carbon dioxide in these subjects. And sure enough, those that had the red light had higher exhaled carbon dioxide levels. So this has obviously huge implications when we're talking about diabetes and glucose sorts of things. Here's actually the study you can see here. Those obviously the 75 grams of glucose made the blood glucose go up. Those in red were getting the red light. Those in gray were not getting the red light. And over here on the right-hand side, you can see those that were getting the red light had higher levels of exhaled carbon dioxide. So proof of concept, physiology at the human level, it's actually working. So let's look and blow it up to the epidemiological levels. Here's a study that was done out of Oxford where they took blood tests on patients. They just drew blood and checked them for triglycerides and insulin sensitivity. And what they did was they looked at the previous 7 days prior to that blood draw, and they asked themselves in the weather report, how many hours of sunlight were there? And you know what they found? They found that the more hours of sunlight that there were before the blood draw was done, not temperature, but sunlight, that correlated to improved insulin sensitivity and reduced triglycerides. Again, suggesting that more sunlight has an effect on the human body even within a few days. All right, what about over years? And what about survival? So this is a study that was done in southern Sweden, published about 8 years ago in 2016. And they took 30,000 Swedish women and asked them, hey, do you avoid the sun? Do you go out into the sun? Do you avidly go out into the sun? Divided them up into those three groups. And what did they find? They found that those that avoided the sun had higher total mortality rates, higher cardiovascular disease mortality rates, higher cancer mortality rates, and higher non-cardiovascular disease. And that the more sunlight that they actually went with, the lower the absolute all-cause mortality got, not just all-cause mortality, cardiovascular disease mortality, cancer disease mortality, and non-cardiovascular disease mortality. Now, this is an associative study, so they say, well, you really can't say causation. But I would look at this, Mike, and that is that there was a dose response curve here, which means that this is highly suggestive of a causal relationship. In fact, the magnitude of sunlight in the study was so large that non-smokers who avoided sun exposure had a life expectancy similar to smokers in the highest sun exposure group. It makes you wonder now that when we have people that go outside to smoke, okay, what are we doing? We're having them go outside. This could actually be the best thing for them because the smoking is offset by the sunlight in this type of thing. Obviously, maybe 20 minutes, 15 minutes is not enough. Maybe it needs more. All right. And by the way, that study was replicated in a recent Texas study that looked at, a UK Biobank study that looked at 10 times the amount of people. So not just women, not just 30,000, but men and women, 300,000 in the UK Biobank study. And you know what they found? Exactly the same results. People who were outside in the sun more had reduction in all-cause mortality, in cardiovascular disease mortality, and yes, cancer mortality. We're concerned that if we go out into the sun, we're going to have more melanoma, more basal cell carcinoma, more squamous cell carcinoma. But in fact, the data shows that there's actually a reduction in all cancer mortality. So here's another study that looked at this. Here we're looking at satellite data at night. Okay, so light in the day is good. What about light at night? Is that good or is that bad? And the studies have shown that it's bad. It's based on studies that looked at satellite data and where people were living. This is the type of data that they're looking at in China to see where people are dying and how close are they to night light. There was this study that was published in the Proceeds of the National Academy of Sciences titled Brighter Nights and Darker Days Predict Higher Mortality Risk. This was a Texas study that looked at 88,000 individuals, UK Biobank, but they were not looking at satellite data. They were actually wearing a device that was measuring light at all hours of the day. This is about 88,000, 89,000. They followed them for 8 years. This is amazing what they found. So they looked at Model 1 And let me see here. Yeah, model one, where they looked at the time of day here on the x-axis. So 16, that's about 4 o'clock in the afternoon to 4 o'clock in the afternoon. And they asked this question: compared to people who get 50th percentile of light exposure and less, what would happen to mortality for people that were in the 50th to 70th percentile? That's here in blue at the bottom. People in the 70th to 90th percentile, that's in purple here in the middle. And people who got the highest amounts of light, 90th to 100 percentile, and that's here in red. Notice, first of all, what happens as we go from 50th to 70th, 70th to 90th, and 90th to 100. Do you notice what happens? The amplitude of this effect gets bigger and bigger. What does that suggest? Dose, response, curve. Again, it implies causation in the Bradford Hill criteria. Okay, what else do you notice? Notice that sunlight at all hours of the day reduces mortality except for from about midnight to about 7 o'clock in the morning. So having bright light from midnight to about 7 o'clock in the morning is not a good thing. In fact, this thing stops to become beneficial at around 9 o'clock at night. And you can see that works in all-cause mortality, cardiometabolic activity, and other cause mortality. Same sort of situation. We're seeing that light during the day is beneficial, light at night is not beneficial. Okay, and this was the findings. They said these findings demonstrate the importance of maintaining a dark environment across late night and early morning hours when the central circadian pacemaker is most sensitive to light and seeking bright light during the day to enhance circadian rhythms. Protection of lighting environments may be especially important in those at risk for both circadian disruption and mortality, such as in intensive care units or aged care settings. Across the general population, avoiding night light and seeking daylight may lead to a reduction in disease burden, especially cardiometabolic diseases, and may increase longevity. Michael, this is exactly the same diseases that we're talking about at the beginning when we're talking about the mitochondrion. We're actually connecting these dots. Let's connect it even more. We said that trees and grass and leaves, highly reflective of infrared light. What do we see when people go out into these spaces? We have known for decades that people who live in green spaces have better outcomes. Notice this: 28% reduction in diabetes type 2, 16% reduction in cardiovascular mortality, 31% reduction in total mortality. And people say, well, look, hey, these people who live in green spaces, they have more money, they have more status, they can exercise more. This is the reason why they have better mortality. Well, I got a study for you. South Louisville, Kentucky, 4 square mile area. They measured CRP levels, which is a surrogate for cardiovascular disease. And then they went and planted 8,000 trees, mature trees with leaves already on them. That's all they did. They just planted trees. Now, according to what we've talked about today, that would improve and increase infrared light, especially when you go outside. That should have beneficial effects just by itself without exercising. Obviously, we didn't inject money into their bank accounts. We didn't do anything else. We just planted the trees. And then 2 to 3 years later, we measured CRP levels again. There was a mind-blowing reduction of CRP in the same population by 13%. That may not sound like a lot, but that's about the equivalent that you would get with exercise, regular exercise 3 times a week. So that's mind-blowing. What did this study of meta-analysis of everybody who gets outside into green spaces find? Well, let me tell you what they found. They said that we found that spending time in or living close to natural green spaces is associated with diverse and significant health benefits. It reduces the risk of, now listen to these diseases, see if they sound familiar: type 2 diabetes, cardiovascular disease, premature death, preterm birth, and increases sleep duration. People living closer to nature also had reduced diastolic blood pressure, heart rate, and stress. In fact, one of the really interesting things that we found is that exposure to green space significantly reduces people's levels of salivary cortisol, a physiological marker of stress. All right. So with all of this evidence, right? All of this evidence, we looked at individual physiological evidence with Glenn Jeffrey's lab. And he's got a whole bunch more tests and studies that we could talk about. Then we talked about the epidemiological tests, and we just kept getting bigger and bigger and bigger and showing these things. You would think at this point that there would be something from the dermatological literature saying, hey, we don't agree with you. Well, in fact, there's a UK dermatologist who published in a very large dermatological paper entitled the Journal of Investigative Dermatology, published just this August in 2024, titled "Sunlight: Time for a Rethink." And this is what he says basically. He says, "Hey, look, there's a number of organizations that have just both produced position statements recognizing that sunlight has beneficial effects that should be considered in formulating policy on sunlight exposure and highlighting the necessity of carrying out further research into these beneficial effects. We should take note." So, in fact, even the dermatologists are recognizing that there are benefits with sunlight exposure. I took note. I'll tell you, there were a lot of questions that I had because I'm a pulmonary and critical care physician. I worked in the intensive care unit. I took care of patients. And I had a lot of questions in the last 4 or 5 years when I saw these COVID patients coming in. One of the first questions I had to do with why these patients that were coming in all had these metabolic disorders. Because we were told initially at the beginning that the patients that we were going to be seeing in the intensive care unit should be respiratory patients because this was a respiratory virus. And while we did have patients with COPD, we did have patients with asthma, that was by far and large not the people that we saw. We saw the people that we talked about at the beginning, the people with mitochondrial dysfunction. And I began to ask myself, why is that the case? So if we go back and look at the mitochondria, which we said the big problem there is oxidative stress. One of the things that we need to look at and understand is that the ACE2 receptor is not just a receptor for the SARS-CoV-2 virus. In fact, the ACE2 receptor is as much more than that. It's actually the modulator of, guess what? Oxidative stress. And so when the virus was spreading around all throughout the country, the world, what was happening is that we were knocking out the ACE2 receptor in the entire population. Now, some of our cars, if you will, were operating a little bit hot. Some of our cars were not operating as hot. Maybe they were in a better situation. But you can imagine that this was like a stress test. Getting SARS-CoV-2 infection was knocking out that ACE2 modulator of oxidative stress. And for some of us, that was going up a hill called COVID-19. And for those of us that had hot engines already where our cooling systems were not working well, we didn't have a lot of melatonin, we didn't have a lot of antioxidants, we had oxidative stress. That was enough to shut down the engine, for it to overheat. And the people that we saw that in were exactly the same people, Michael, that we talked about at the beginning of this presentation. Heart disease, diabetes, obesity, dementia, inflammation, and cancer. These were exactly the same people that I was seeing in my intensive care unit that were not doing well. But I said that I had a couple of questions. Here was the other question that I had. We knew very early on that people that were coming into the intensive care unit had vitamin D levels. Those that had high vitamin D levels or normal vitamin D levels did very well. Those that had low vitamin D levels did not do well. Now, we know that correlation does not necessarily mean causation, but what we decided to do, because it was very low risk, was to supplement these people with oral vitamin D. And there were some studies that seemed to show that it may have helped out, but there were other studies, plenty of those studies, that did not show any benefit whatsoever. So I began to wonder whether or not vitamin D was helping a little bit, but was more of a marker of something else that they were getting that was helping them out. And of course, the way that you get vitamin D levels elevated is to go out into the sun. So I began to wonder whether or not, in fact, people with high vitamin D levels were doing well, not just because they had high vitamin D levels from a fraction of the sunlight, which is UVB exposure, but in fact from the rest of the 53% of the photons from the sun that are in the infrared spectrum that we've already shown improves melatonin in the intracellular area, in the mitochondria. And of course, that's a very powerful antioxidant. And of course, if COVID-19 is a oxidative stress disease, this could have very huge implications. So I began to look at data. And here we look at the data here. This is a paper that was published in January of 2021 in Scientific Reports. And what they did here was they looked at the surges of COVID-19 in the autumn of 2020. So as the sun started to come down in the northern hemisphere and start to drop into the southern hemisphere, certain countries started to get picked off one by one, and we started to see one by one that these countries were having surges, starting first with Finland, ending up last with Greece. So this did not correlate with temperature. This did not correlate with humidity. What it correlated was with latitude, 100%, perfect correlation. Then I began to think, okay, maybe there's something here to this sunlight question. Then there was another study that was published in April of 2021 in Epidemiology, again, looking at this time not the amount of COVID happening, but the mortality of COVID happening. And what they found was that, sure enough, in not only the United States, but also in England and again in Italy, prospectively, they found basically that the more sunlight there was, the lower the COVID-19 mortality was in that area. And they published this. In fact, they said it suggests that optimizing sun exposure may be a possible public health intervention. Given that the effect appears independent of a vitamin D pathway, it suggests possible new COVID-19 therapies. That was amazing. So I took that opportunity to look, and I actually teamed up with Margaret Scutch, who is a geographist, and she looked at the global situation, and we looked at countries that had a greater than 50% overweight rate, and we asked the question, does COVID-19 correlate with latitude of these countries, generally speaking? And the answer was absolutely. Limiting countries to more than to just the 50% of the population being overweight or higher, there was a definite association. We actually published that in June of 2022 in Melatonin Research. But let me just back up a little bit here because it's not just COVID. Truth be told here, if you look at every single natural cause of death, whether it be heart disease, stroke, chronic lower respiratory disease, Alzheimer's disease, diabetes, influenza, kidney disease, you name it, anything that goes on the death certificate from a natural cause. Look here, Michael, look at this very carefully. They all peak right at the end of the year. So literally just weeks after the shortest day of the year, every single year. It's just incredible. And it's not just heart disease, it's all of them. So it's not just a situation where you say, okay, well, maybe we're all going inside because it's cold and we're spreading the germs around. Okay, I could understand that maybe for an infectious disease, but heart disease, kidney disease, these are not infectious diseases, right? These are all peaking at that period and that time of year. Here's another way of looking at it. By the way, if I were to show you Australia's version of this chart, and I don't have it with me at the moment, but if I were to show you Australia's version of this chart, it shifted 6 months. So it's still happening about a week or so after the shortest day of the year, but their shortest day of the year is in July, right? Because they're in the southern hemisphere. By the way, the coldest month in Australia is July. Yet the average highs in July is like in the mid 60s in Australia. So it's not even cold in December. You can't use that as an excuse that everybody's going inside and putting on the heating and you're spreading around these viruses. This has to do with the amount of sunlight that people are getting. I am convinced. So let's focus in on the flu. Again, very clearly, this flu deaths, we can predict exactly when it's going to happen, and it always happens every year just a few weeks after the shortest day of the year. And we've already shown you that sunlight can have an effect on the human body literally within days. So that changes very quickly. But don't take my word for it. Let's look at the Harvard Kennedy School. They did a study that looked at solar radiation data from the National Solar Radiation Database and CDC data for influenza. And they were able to actually look at 2009, which you may recall, we had an epidemic of H1N1 that year that came in really early. So like in July, August, September, well before the normal flu season, there was reduced sunlight across the country and it was in specific areas. So we were able to actually look at this in terms of temperature, in terms of humidity, and in terms of sunlight. And guess what the Harvard Kennedy School found? They said, quote, "We find that sunlight strongly protects against getting influenza." So it's not a temperature or humidity thing. All right, so what is it that's actually happening? Why would sunlight be beneficial? Well, this is a study that was published, back in 2021, looking at infrared light therapy. That's the majority of the photons coming from the sun, bar none. What they do is it actually shows that it reduces toll-like receptor 4 dependent hyperinflammation. You can see the data here on the right-hand side. It reduces IL-6. We actually have drug medications in FDA approval that is supposed to do exactly that same thing for COVID-19. Guess what? Infrared light does the same thing. It drops IL-6, whether it's coming from an LED or an incandescent bulb. It does exactly the same thing. IL-8, same thing. Tumor necrosis factor alpha, same thing. Interferon alpha and interferon beta are interferons which stimulate the humoral arm or the adaptive arm of the immune system. This is exactly what is ramping up after 7 days of COVID-19, and you're getting that cytokine storm, getting into the intensive care unit, and getting intubated. This is what we want to reduce, as opposed to the gamma interferon, which is more cell mediated, which is where it actually breaks down cells that are already infected. And guess what? Chronic exposure to natural sunlight actually has the opposite effect of that. That's why this is so beneficial. Getting out into the sunlight when you come down with an infection is going to help clear up the virus, and it's going to mitigate, reduce, attenuate that humoral response on day 7. So impressive. But you're saying here, probably at this point, Michael, you're saying, okay, this is a lot of circumstantial data that seems to suggest it. What we really need is a randomized, placebo-controlled trial that actually takes patients with this disease, gives some of them randomly infrared light and some of them placebo. Well, I've got that study here for you, published in a very top photobiomodulation journal, 95 percentile in terms of impact factor, published in January of 2023 by Pereira et al. They did a very carefully conducted inclusion criteria, 30 inpatients between the ages of 50 and 80 with a diagnosis of COVID-19, BMI of less than 30, no cancer, no photosensitivity, not intubated, but sick enough to actually be admitted to the hospital. And they did a very simple experiment. They actually made a jacket with infrared light LEDs that, of course, are broadcasting in a light that you can't see, so it's blinded by definition. And it was at 940 nanometers. And they did this for just 15 minutes a day. Just 15 minutes a day. That was it. For 7 days. And they asked the question, what happened? Well, actually, the randomization of those two groups was a little bit off, but it actually turned out that the people in the intervention group, the near infrared group, were actually slightly sicker than those that were in the control group. So the randomization actually was biased against the intervention group. Nevertheless, what happened? In the NIR group, oxygen saturation improved higher and faster than the control group. Those patients were able to take deeper and stronger breaths after those 7 days. The respiratory rate and the heart rate improved faster than in the control group. The lymphocytes, which are extremely important in getting rid of cells that are infected with the virus, instead of in the control group where they continued to drop down because the virus were infecting them, there was actually an increase of 850 cells per cubic millimeter. But here's the most mind-blowing statistic here in terms of endpoints. People who got near infrared light for just 15 minutes a day were discharged a full 4 days faster than those in the control group. I don't have to tell you that has huge implications in terms of the finances in hospitals, actually on the positive. So many hospitals, what they'll do is when they have a patient that gets admitted with a specific diagnosis, the insurance company will pay a block sum for that diagnosis. And it's up to the hospital to get that patient quicker, faster, better, and out the door so they can take the profits on that, whatever was given to them, and not have the expenses of a patient taking up a hospital bed and having a nurse. So that's called a DRG. There's also something called subcapitation or capitation, where the hospital is paid per member per month. So I don't have to tell you that if we can somehow get patients better, faster, and out the door, that has huge implications in terms of finances. Just to give you an idea, Tamiflu, which was FDA approved for influenza, was FDA approved on the basis of ending the symptoms of influenza 24 hours faster. We're talking 4 times that amount here with just natural, well, not natural sunlight, but infrared light, which is in natural sunlight. So when I learned this, Michael, I have to tell you that I was convinced. I was treating patients during the bulk of the pandemic in the ICU phase with vitamin D, thinking I was doing them favors. When I started to learn this, by that point, many of the patients coming into the hospital were no longer requiring ICU care. And I vowed that if I ever had another patient like that, I would try it out on them. Well, about a year ago, in about October of 2023, I had a patient that was admitted to the hospital for 2 days with COVID. And despite the fact that he was on solumedrol, azithromycin, some of these things that we treat the patients with, basically the standard of care, for those 2 days, he went from 4 liters of oxygen nasal cannula to 10 liters oximizer. Finally, they called me when he was on 35 liters, 100% FiO2, and almost ready to be intubated. I went down to his hospital room, opened the door after I gowned up and put a mask on, and found this guy in the dark with the window closed and his daughter. He was depressed. He wanted to know how much time he had. I immediately felt the urge to get him outside, talk to our respiratory therapist, talk to our charge nurse. They put their heads together, put oxygen tanks together, and got him into a wheelchair. He didn't really want to do it. We had to convince him to do it. But we did it for about 20 to 30 minutes every day. I got him out into the sunlight. The next day, he was down to 15 liters oximizer, then 10, then 6 liters nasal cannula, then 4. And then by day 19, he was discharged from the hospital without the need of any oxygen. This is a picture of that first day that we took him outside. You can see that we've got a nice little garden in our hospital that's got nice green plants that are highly reflective of infrared light. We have some trees. It's in a private area in the hospital so that people from the outside can't look in. This is his daughter here on the left, the respiratory therapist Kim, my charge nurse Peter. I had permission from the patient to take this picture. I could have taken it from the front. I just didn't want to do that, so I took it from the back to give him some privacy. But he did very well. You know what he told me about 2 weeks later? He said, "You know, that first day that you got me out there, Dr. Seheult, that sun felt so good, so good." I thought I had a new treatment for COVID-19, Michael. I thought this is it. We've discovered something new. But to quote a very wise king from the Old Testament, there is nothing new under the sun. Pun intended. 100 years ago, there was a lady by the name of Florence Nightingale, who's actually the founder of modern nursing. She gave up a very rich family lifestyle, and she decided to go into nursing. That was not something that young women did if they could choose not to do it. And she took care of British soldiers during the Crimean War. She was known as the Lady with the Lamp. She visited them. She was there at the bedside. This is what she said in terms of what helped. She says, of all the remedies that I've used or seen in use, I can find but one thing that I can call remedial for the whole disease, and that is a profuse supply of fresh air. Second only to fresh air, however, I should be inclined to rank light in importance of the sick for the sick. Direct sunlight, not only daylight, is necessary for a speedy recovery. Not just Florence Nightingale on the European continent, but also here in the United States. There was a health reformer, actually the founder of Loma Linda University, where I hail from, Ellen G. White. This is what she said in 1871. She says, "The feeble one should press out into the sunshine as earnestly and naturally as do the shaded plants and vines. The pale and sickly grain blade that has struggled up out of the cold of early spring puts out the natural and healthy deep green after enjoying for a few days the health and life-giving rays of the sun. Go out into the light and warmth of the glorious sun, you pale and sickly ones, and share with vegetation its life-dealing, health-giving power." The other thing that she said that I found really interesting based on that study that we looked at with light and not having light on at night, they could see this as well. She says, make it a habit not to sit up after 9 o'clock. Every light should be extinguished. This turning of night into day is a wretched, health-destroying habit. And sure enough, this is exactly what they did. They practiced what they preached. As you can see here, Michael, they had hospitals that were specifically designed to get patients outside into the sun. You can see the doors and the beds are of exactly the right dimensions so that the doors are not blocked. The patio here is the right length to store them. This was built in to the architecture of getting people better in these hospitals and these sanitariums. Here we see girls post-operative getting sunlight for their ills, and the roof of the hospitals had beds out there for patients. This is something that we did, something that was very effective, and we could see it even without the scientific accoutrements that we have today. Well, what about the data that we see? Well, one thing that's really important for hospitals is getting good surveys. And there's a lot of data on this. People who are in rooms that are next to the window get better faster. This was a study that looked at this, and they found that researchers have found that a patient's hospital room might affect their outcomes after surgery. For example, having a window in their room was associated with a faster recovery after surgery. What about these CAP G scores? These are really important. And in every situation, whether you're talking about windows or no windows, the presence of windows, the view to a window, the view of the content in that window, whether there's green spaces, in all of these situations, when the patients fill out the survey for their experience in the hospital, it's always improved whenever these things are involved. You can see window size, more windows. So look, this is the best situation you could possibly have. This is something that is generally free. You don't need a supply chain. It helps the patients. It can help the hospital financially, and you get better scores. There's really no downside to it. I mean, in terms of relieving stress, all the way down the line, every single situation, we're seeing better scores in patients who are having that in the hospital. All right, last thing I want to talk to you about is a case study that I found just absolutely astounding and really told me and educated me on how powerful this effect could possibly be. So this was a lady that called me up a couple of weeks ago. Um, and she doesn't mind me telling this story. She gave me permission to tell the story. In fact, she gave me the CT scans, which I'm going to show you. Her 15-year-old son was diagnosed with a very aggressive form of B-cell lymphocytic lymphoma back in September of last year, in 2023. Started chemo right away, and in May of the next year, developed a pneumonia. He had 2 to 3 weeks of cough, runny nose, went into the hospital with neutropenic fever. This is a very common situation where the chemotherapy knocks out the immune system, it knocks down your neutrophils, you develop a fever. The typical thing is you go into the hospital, you get antibiotics, you get better, you're discharged. That's not what happened here. Unfortunately, he developed a pretty strong infection in the left lung. Turned out to be a flesh-eating mucormycosis or flesh-eating fungus. So he was immediately put on very, very powerful antifungals and had a bronchoscopy. It showed that it was getting worse. He had chest tubes. Finally, they came to the unfortunate conclusion that the only way to save his life was to remove that left lung, which he had done. And soon after that, that was in July, so he'd already been in the hospital for a month, inside a hospital, no sunlight, no natural light, under the LED bulbs, the fluorescent bulbs, the windows that blocked out infrared light, just basically in this hospital. Unfortunately, after that lung was taken out, that did not solve the problem because the fungus spread to the right lung. And it showed that he was getting worse. His oxygen requirements were getting worse. And about 6 weeks after admission to the hospital, the unfortunate conclusion of all of this was that he was not getting better, and they were concerned that he was going to need to be intubated on a ventilator. And if that was going to happen, there was no way he was going to get off. So I show you here different cuts through his chest. You can see here that the left lung here on this side is actually on the right side of the screen. It's all white because there is no lung there. It's just filled up with fluid. The top one here is the top slice through the top portion of the lung. You can see here that the right lung is very white and inflamed. That is what it was looking like. You can see here in the middle portion of the lung, same situation. There was a little bit of sparing in the lower portion of the right lung where you see more black. That's what it should look like because the lung should be filled with air. So there was a multidisciplinary care conference. They looked it over everything. We're talking about the oncologist. We're talking about the thoracic surgeon. There was nothing further they could offer the patient. Bronchoscopy, thoracentesis, these are procedures which would just sort of rearrange the chairs on this sinking ship. They basically had to come to the family, and it was a very emotional decision. But basically, they had to tell this guy, this 15-year-old boy, who was completely with it, completely understand everything that was going on, that he was about to die, that he had about probably 2 days left to live because of the progression of this disease. So, and I can tell you as a healthcare provider in that kind of situation, you feel horrible and you're willing to do anything that patient wants. He's about to die. You're looking at a dead man, basically. And if he asks for something, you're going to do everything that you possibly can do for him. In this case, he expressed a desire on July 16th, which is when the scan was done, to just go outside. He just wanted to go outside because he liked going outside. Now, at this point, I should tell you that there was a device that the family had been told about during this called a Firefly device, which gives off light in not only the ultraviolet spectrum, but also the infrared spectrum. And they had tried it occasionally, off and on during this 6 weeks while he was in the hospital. Obviously, didn't have much benefit. But what they decided to do on 7/17, because he made this desire, it was not easy to do. They had to, again, put tanks together, get a BiPAP machine, which he was already on, very high, 100% oxygen, to get him outside. It wasn't easy. But he was outside on 7/17 from 2 to 6 p.m. So he was out there for about 4 hours. He had a fever that day, and the white blood cell count was very elevated at 27.5. Most of those were neutrophils. It was fighting the infection. Next day, went out for another about 4.5 hours, and they tried the Firefly at that point, which is that device I just showed you, just for 5 minutes, 3 times a day. Plus, he was outside. At that point, the fever had disappeared. The white blood cell count had come down precipitously to 18.0, neutrophils down to 13.7. 2 days had come and gone. He wasn't dead. Went outside again, this time for about an hour. Firefly again for about 5 minutes, 3 times a day. Fever completely gone. White blood cell count continues to drop precipitously to the neutrophils down to 4.8. On 7/20, the physician team started to scratch their head. What was going on? His oxygen requirements were coming down throughout this period of time. He was actually looking better. He was outside for another 3.5 hours. Again, Firefly, 5 minutes, 3 times a day, fever completely gone. Oxygen requirements went down. At this point, they said, hey, maybe we were wrong about something. If he looks better and the antibiotics are working, then maybe we could try getting him back on chemotherapy. I want to show you what happened when they got another CAT scan to see how he was doing. So again, I put up here the 3 representative CT scans of what happened on the 16th of July and how involved these were. And after just 4 to 5 days of getting outside into the sunlight and also using that Firefly device, so I can't tell you which one it was, but I believe it was probably both. Just the sunlight, look at the difference. Look at the difference between the circles. Circles on the left are exactly at the same place in the lung as a circle on the right, and you can see a dramatic improvement in the inflammation. So when I look at this, I think about that study with the toll-like receptor 4. Well, I think about melatonin. I think about reducing all of the cytokines. I think about boosting the immune system. I think about the lymphocytes that went up in that study, in that randomized controlled study. And I can't help but think, wow, this guy asked to go outside. Imagine if he'd asked just to play a few video games. He might not be with us. And the fact of the matter is that he continued to get better. And this was in July of this year, in 2024, and was able to be discharged home, still battling the acute lymphocytic leukemia, still getting the chemotherapy for that, but no longer an issue with mucormycosis. In fact, this is the lung CT that was done last month. And I just decided to do one shot because it looks like this all throughout the entire lung. It is completely gone. There is no sign whatsoever of this fungal infection in this patient. Hard to believe, but incredible that the sun would actually have that much power. It began to make me think about how little time we spend in the sun. I can't help but think what Ellen G. White wrote when she founded Loma Linda University, which is where I graduated from. And she said, this is what she said. And I just putting all this together and how powerful this is. She says, I have a decided message for our people in Southern California. This is where I work. For months, I've carried on my soul the burden of medical missionary work in Southern California. Recently, much light has been given me in regard to the manner in which God desires us to conduct sanitarium work. We are to encourage the patients to spend much of their time outdoors. That is just incredible to me. And I'll tell you why. I think that we need to be getting intentional sunlight, getting outside for 20 to 30 minutes per day, especially in the wintertime when it's the hardest to do it, when the sun gets up after we go to work and the sun goes down before we get home. Yeah, it's hard to do, but I believe that that's the most essential time to do it. And let me explain why. We spend 93% of our lives inside. We are not able to get that infrared light because we're not outside to get it. It cannot penetrate through the walls. The lights that we now have in our homes are not incandescent lights that give off infrared light. They're LED bulbs that have had specifically that portion of the spectrum cut out of them in the name of energy efficiency. Same thing with the windows in our modern buildings. They are blocking infrared light from coming in because it heats up the building and it causes air conditioning costs. And I can't help but think that this may be the reason why we have an increase in chronic disease. So we need an inpatient heliotherapy protocol. I'm actually trying to work on getting that done in some of our hospitals where I work. It'd be nice to be able to select those types of things in our patients to say, yes, I want this patient to go outside. We would need an army of volunteers in the community to do that. We'd have to watch them very carefully because obviously it's not easy to transport patients that are critical. You have to make sure that if something happens to them, that you're ready to take care of that. But think about what it could do to the length of stay. Think about finances, what it could do with in terms of the beds that we have to take care of patients. If they're leaving the hospital faster, now we have more beds to take care of patients that are coming in. So we will end this presentation where we started it. And you'll see why I'm so passionate about this. Because I want everyone to have longevity. I want everyone to live as long and as healthy as they possibly can. The problem is that chronic disease is the enemy of longevity. And we know that chronic disease is everywhere. So the next time you see or come face to face with chronic disease, I want you to look it straight in the eye and say, let's take this fight outside.
That was great. That was great. Thanks, Roger. So I guess we'll take it off full screen and then questions.
Yeah, I'm open to questions.
Yeah. All right. So I think so. There's obviously a U-shaped curve with sunlight and health, right? Too little, it goes up the U, and well, the argument could be made how much is too much, right? Even though people who were not sun avoider, so people who avoided the sun had an increased all-cause mortality risk. You could make the argument that too much sun exposure, photoaging, accelerated skin aging. So there might be some, you're going up the U, right? So you mentioned 20 to 30 minutes. How can we get towards a more precise dose, or how can we get to, yeah, the more precise dose, or is that the most precise dose for getting, minimizing risk? And yeah.
Good question. So we've got two extreme opposites, not just in terms of the U, but in terms of the types of data that we have. So we have epidemiological data that's really robust that shows not only in the Southern Sweden study, but also in the UK Biobank study that we have not yet reached a limit of sunlight exposure and improvement in longevity. It wasn't like we saw a bell-shaped curve in those epidemiological studies, right? The ones that were exposed to sun the most had the best longevity. But we know that we don't want people frying out in the sun, right? We kind of know that intuitively. So the point there shortly is I don't know where the upper limit of that is epidemiologically. I think we need more data on that. On the other flip side, when you look at Glenn Jeffrey and his lab, what he is finding out, and he sees this not just in humans, this phenomenon that I'm about to explain to you is not specific to just humans. It's also seen in bees, it's seen in fruit flies. I mean, it's seen up and down across species, and that is this thing called the biphasic response of light, which is that it takes a certain amount of time for light to make its effect on the mitochondria. And what he's seeing is about 15 to 20 minutes is what he sees. And then further exposure to light after that has diminishing marginal utility. So this is where I come up with, I'm trying to marry these two things together. And I'm trying to say uh, that we don't need to be frying out in the sun every single day. And certainly that's going to cause skin damage. But perhaps maybe on a daily basis, all it takes is for us to get out there for 20 to 30 minutes to get the effect that we need in the mitochondria and not accrue the detrimental effects of skin damage and all of this damage that we get from UV radiation. So there's a couple of studies in terms of that where this was published about 2021, where he took people who had difficulty with their vision, and it was because of they could not sense the difference between colors. So what he was able to show was that when he exposed to their eyes to red light, 670 nanometer light, for just 2 to 3 minutes in the morning specifically, it had to be in the morning, he was able to show that for the next 3 to 4 days, there was a dramatic improvement in visual acuity between colors. Now remember that the retina is the tissue in the body with the highest concentration of mitochondria. So that's where we would expect to see that improvement. But it seems as though just for some reason, just a few minutes, maybe 10, maybe 15, maybe longer. It's hard to say. And obviously, we need studies to look at that. But the effect that he is seeing, it's like almost a switch turns on after a certain amount of time. It's not like this linear relationship, and the effect can last for days.
Which then goes to, I think in one of your videos, you mentioned like time of day too. So could the dose at time of day be an important factor too? I mean, should we be getting the sunlight, near infrared, and red photons, or is it we want a combination of midday UV and the? So what are your thoughts on that?
So it depends on the effect that we're looking for. If we're looking for the effect of light on the circadian rhythm, there's no question that time of day absolutely matters. And it's because that the intrinsically photosensitive retinal ganglion cells, which are in the lower portion of the retina, are not as sensitive in the morning as they are in the evening. So it's much more important to avoid light. You have to do a really good job of avoiding light in the evening, and you really have to do a tremendous job of getting light to the eyes in the morning time. Now, if we're talking about infrared light going through the body and going into the mitochondria, this is the situation where we're not dealing with intrinsically photosensitive retinal ganglion cells. I don't know whether or not there is a circadian rhythm situation there. It may just simply be that light needs to get into the mitochondria and has nothing to do with circadian rhythm. But I'll tell you this, before when we've made assumptions that something had nothing to do with circadian rhythm, we've been wrong before. So it might actually be involved even at that level.
So, in terms of the circadian rhythm alignment with light exposure, I think you also mentioned in one of your videos about cortisol, the cortisol and melatonin link there. So, I
Yep.
guess not getting the morning light, then there's going to be a rise in cortisol, and then nighttime awakening in the middle of the night, and you're not setting the melatonin. So, could you just go through that? Because I think that's a brilliant, yeah.
Absolutely. So cortisol is the hormone of the day at the beginning of the day, and melatonin is the hormone of the beginning of the night. And the way you really want those are in pulses. So if you don't get morning sunlight, that pulse of cortisol that you should be getting to get the body ready to go and tuned is going to be more delayed, and you're not going to get the effect of that cortisol as much as if you got morning light and that peak of cortisol to start your day off in the morning. It's like a cup of coffee. Literally, I mean, I've heard people talk about how it feels to them. Morning sunlight it gives them the energy of a cup of coffee, of course, without the coffee. The same thing happens in the evening time, except that it's the lack of sunlight that does it. It's the lack of artificial light that does this. So not having light around 9 o'clock, 10 o'clock, 11 o'clock allows this peak of melatonin to be able to occur from the pineal gland because it's not being shut down by the light being shone into your eyes. This also happens. And so you really need both of these things to be able to occur. Lack of light after 9 o'clock and bright, shining light at 9 o'clock in the morning to allow that cortisol level for the day.
So if you can't get the sunlight in the morning, like as you said, most of us are getting up before the sun comes up, so then is it a red light panel? Is it a combined red near infrared panel? Or how would you?
I don't think it needs to be a red light panel to get the cortisol. So any kind of light, in fact, you could even buy these on Amazon for 20 bucks called a SAD light or SAD light. This type of light is going to hit the intrinsically photosensitive retinal ganglion cells, which have their peak in the blue area, but the light that's in front of you is white. It's going to have plenty of that blue light that it needs, and it's going to trigger that and cause two effects. The first effect is going to set the circadian rhythm through the intrinsically photosensitive retinal ganglion cell pathway. The second is going to the perihabenular nucleus, which is the nucleus of the brain that is implied with seasonal affective disorder. So this is a disorder that typically affects people in the winter months, a little bit more females than males, and you can basically eliminate seasonal affective disorder by buying a SAD light, putting it in front of you in the morning for about 20 minutes, about 11 to 15 inches from your eyes, and it's usually about 10,000 lux, which is the brightness that you need to have.
So that would affect seasonal affective disorder, in northern latitudes in the winter, for example. But uh, does that cover the full spectrum in terms of, the red light and near infrared light, aside from effects on?
No, it wouldn't. So this is circadian in general. So what do we do when we want to get the infrared light? That's really important. And this satellite is not going to be able to do that. What you need to do is to get outside. Look, even I was just in Edmonton about a month ago, and granted, it's not the shortest day of the year yet. I was still able to get outside. I was still able to see that sun, even though it's low in the sky. Remember, the near infrared light is able to penetrate even at that low level. For those of you who live in cold weather climates, you know that during the wintertime, one of the most dangerous things on the road is black ice. How does black ice form? It's very simple. Black ice forms when precipitation comes down in the form of snow, and then the sun comes up and melts that snow. And then at night it refreezes. That's how you get black ice. Realize that the sun is actually melting the snow to get that black ice. What portion of the sun is melting that snow? It's infrared light. So you have to actually get outside and get into the infrared light. Yes, it's cold. Put on a couple of layers. It should penetrate through, but you need to get that infrared light. Okay, let's say that there's no way you're able to get it, even with my chiding you to do so. What are other ways that people have gotten near infrared light in cold weather climates where the sun doesn't come up? Natural fires. So, fireplaces, this black body radiation that comes out of the fire does actually give off a whole band of infrared light and near infrared light.
Fantastic. All right. So biomarkers of sunlight exposure being vitamin D, UVB, right? So what about, and granted, in meta-analyses, there may not be an upper limit for circulating levels of vitamin D's association with all-cause mortality risk. For example, just being higher than 30 nanograms per mil, and at least one meta-analysis from 2014 that I commonly cite. It basically, you see all-cause mortality risk come down and then basically flatline, even at very high levels of circulating vitamin D, which suggests that potentially sunlight, even at very high amounts or megadosing D supplements, may not increase all-cause mortality risk. But what about biomarkers for, not just the UVB spectrum, with vitamin D being, a marker of that, but red and near infrared, what would we look at?
Yeah.
Could it be blood pressure when considering a nitric oxide, or what would you think along those lines?
So nitric oxide is one that's emerging. It's very short-lived, so it's got a short half-life. One they're actually working on, believe it or not, is melatonin in sweat. So this is something that they're actually looking at seeing whether or not this could be a good surrogate for infrared light. There are developing light meters that actually measure infrared light. But if it's true that infrared light can stimulate the mitochondria to make melatonin, what they have been finding in some of the studies that have looked at this is that they're finding that the melatonin concentration in the sweat is higher, obviously, than the melatonin concentration in the bloodstream. What does that mean? It's got to be made locally. And so if it's being made locally, that's one way of measuring the effect of infrared light. It's difficult to do because the effects that we're seeing are occurring in an organelle of the cell. So this is not something that's readily available. You have to be able to get markers inside of organelles of cells to figure out whether or not the effect is actually happening. But they may have it with melatonin. We know for 100% sure that melatonin is made in the mitochondria. We believe that it's related to infrared light's effect on the electron transport chain, but that is still being worked out.
So the concentration of melatonin in mitochondria should be proportional to the concentration in the cytoplasm in the extracellular space, and then potentially higher in the blood, right? So,
Well, I don't know if it's actively transported out. I do know that melatonin that's in the bloodstream goes into the mitochondria because that's where it's being produced. Sorry, that's where it's being used. It's also being produced there. So I don't know if the melatonin is actually going down a concentration gradient outside the mitochondria because it seems as though most of the oxidative stress and most of the use of the melatonin is right there in the mitochondria.
So then a point of clarification, because I've heard you mention that melatonin is the, I think, most powerful antioxidant in the mitochondria or inside the cell. But
Yep.
I looked up the reaction rate constants for melatonin versus superoxide and hydrogen peroxide, and it's on par with glutathione. So the reaction rate constant being in the same ballpark for both superoxide and hydrogen peroxide. But as I'm sure you know, superoxide dismutase, which scavenges superoxide and converts it into hydrogen peroxide, the reaction rate constant is like 10 to the ninth, whereas for melatonin, I think it's like 10 to the third or 10 to the sixth. So, 1,000 times faster for the enzymes. So I guess uh, with a point of clarification, would it be that melatonin is the non-enzymatic, potentially best antioxidant or on par with the best? I don't know. Could you clarify?
Well, the reason why I say that is because the next closest is glutathione, and actually melatonin itself regulates the regulation of glutathione and upregulates glutathione. So if you have it by itself, of course, in a test tube in a laboratory where you're looking at enzyme constants, there may be ones that are on par, but the way that the body is set up in the system, when melatonin is being produced, it actually activates and upregulates glutathione. So in a human system, melatonin is the most powerful antioxidant because of its effects, not just enzymatically, but also on regulation.
So then, all right, now the story gets really interesting for me there because glutathione levels decline during aging, melatonin levels decline during aging. Sunlight can impact intramitochondrial levels of melatonin, but where the story gets really interesting is that tryptophan is required you got a couple enzymatic steps for conversion into melatonin. Tryptophan levels decline during aging too. So, and part of that is because more of it reaches the gut where it's fermented or converted by gut bacteria into other metabolites. So yeah, I don't know. I don't think I have a question there, but there's a lot going on with the melatonin, tryptophan, and glutathione story.
Sure. And so the question was, it will be important if tryptophan goes down, if tryptophan is the rate limiting step. What we're seeing in individuals physiologically, at least in Glenn Jeffrey's lab, is that that's not a rate limiting step. The rate limiting step, it appears, is red light and its effect on the electron transport chain.
Interesting. All right, cool. All right, so then the built space. So I recently bought a house and now I'm obsessed with, the windows. What kind of windows should I have? And you mentioned, the E windows, which or E gain, I guess they're called.
Low E gain, yeah.
Yeah. So what kind of windows would be best for letting the red and near infrared in? And do they sell windows that block UV and the blue, but allow the red and near infrared in?
They do. You've got to look for them. It's not easy, especially if you're trying to get windows for a home. So I just recently put up a greenhouse in my backyard. It's a greenhouse actually out of Belgium, and the windows there are great. I can feel the heat. I can feel the warmth. Of course, they're designed for that, right? They're designed for heat and warmth and multi-spectrum light to come in. Not so for the windows that I just, when I bought my house 15 years ago and I wanted to upgrade the windows. Of course, I didn't know anything about this. And so I've got great low E glass that doesn't allow it in. It's complicated. If you're able to get access to windows that don't have low E, it's possible, especially in Canada and in higher latitude countries where you don't really want to block infrared because it's actually a way of help heating. It's another way of reducing costs from a heating standpoint. Obviously, in Southern California, where I live, those type of windows are going to be very rare because most of the problems that we have here is not a heating problem, it's a cooling problem. So you've got to be creative. But I think at the end of the day, what is this going to depend on? When they're building homes now, at least where I live here in Southern California, they don't put sockets in where you can put incandescent bulbs and LED bulbs that screw in. They're on purpose putting in receptacles that where you cannot put incandescent bulbs in. You're forced to put LED bulbs in. And that's why I conclude that, there are some things that are out of our ability to change, uh, just because it's so difficult to do unless you have the money and the ability to do this, because you got to get signed off right by the contractors and the people that inspect. So at the end of the day, what's the most important thing to do? You got to get outside. You just got to get outside. You got to open the windows because up till now they can't change light. It's free. It doesn't require a supply chain. It's always going to be there. We in Southern California have probably the most amount of sun days in the country. Maybe Florida might have more, but they get some rain clouds there too. It's still good. For those that don't have it, like up in Seattle, I'm convinced that the biological effects that Glenn Jeffrey is showing in his lab, where he's able to shine light for just a few minutes in the morning and have effects for a couple of days, might be the saving grace. Like if you're able to get out when there is sun, that might be good for you for the next 2 to 3 days and help out. That study that we showed at Oxford, where in the previous 7 days, for every increased hour of sunlight there was in the previous 7 days, there was a better lipid profile, increased insulin sensitivity. So I do believe that the effect of sunlight on the human being is very quick. It's very rapid. And I think vitamin D is just one slice of that.
Cool. That was great. All right. So what's coming next for Medcram? Are there videos that you're working on that are soon to come that yeah.
Yeah, so this is my perennial topic. One thing that I would really love to get into as well, and I'm starting to look at this, is the effect of temperature on the human body in terms of fighting viruses and diseases. And I think there's a lot of data, whether it's sauna data, whether it's hydrotherapy data, whether it's data where we don't treat a fever. There's a recent paper that I've just come across that was published a couple of years ago looking at the mRNA transcripts of particular viral fighting proteins that improve with just a small elevation of temperature. I think this is something that, at least in the medical world, we're trained to treat as an abnormality. If somebody has a fever, the nurse calls the doctor orders Tylenol, and we bring the fever down and thinking we've done something good. I actually think that that's detrimental. And one of the things that I'd love to do is not only talk about people getting outside in the sun at least for 15 to 20 minutes a day. Hey, but the next time you have a fever that's reasonable, not above 103, maybe worthwhile not treating the fever and maybe even going the extra mile and saying, let's say you're feeling sick and you don't have a fever, maybe instituting a fever, maybe increasing your body temperature to induce some of those innate immune system reactions may be beneficial.
Does thermoregulation decline during aging? Do older people have a harder time raising their body temperature?
Absolutely. And actually, that is exactly what the focus of this paper that I'm reviewing is that they're saying that this actually may explain why so many people during the pandemic, the COVID-19 pandemic, who are older, died of it because of exactly what you just said.
Interesting. All right. Fantastic. Thanks, Roger. I appreciate you coming on, and hopefully we'll have you back on at some point.
Thank you so much.
Cool. Thanks, Roger. Bye.
Bye-bye.